All right. Hello, 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 my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, March 10th, and I've been away. I'm so sorry. I got COVID and then I got pneumonia. I have never had pneumonia in my life, and it was not fun. I ended up at the emergency room twice. 2 weeks ago, as a matter of fact. And it also, hey, Kayleen, it also messed with my heart. So I was having some heart problems, but all is better now. I am vertical. I have been walking. Yes, I have come to realize that my daily health and sanity is very dependent upon my ability to exercise. And there's just nothing worse than asking me to stay home and rest. I want to be out. In fact, I did everything this morning and then I went out and walked 45 minutes and I just got back about 20 minutes ago. So, anyway, my purpose in doing these support group meetings is to help patients who struggle with pelvic pain and bladder pain and pelvic floor dysfunction and COVID cystitis and Hunner's lesions and UTI and all that sort of stuff. Hi, Donna. I know you were worried. I'm sorry. Life. Honestly, I really realized that my immune system took a big hit. It took a big hit in the last 6 months, obviously. And so I'm definitely better. I'm definitely vertical. We'll see if I cough. Hopefully I won't. So we should be good. Anyway, getting back to why do I do these meetings? Well, I'm the national IC support group leader. I have been doing support group meetings for patients with IC and bladder pain and pelvic pain and prostate pain for 30 years. And you know what? They're free. And they always have been free. I was working with a patient, very interesting patient I've worked with a couple of times on Friday. And she called and she was just in a real crisis. And she just wanted to talk and she wanted to pay me for it. And I said no. She was in crisis. She was crying. I am not going to be a predator in that respect. And we talked for 2 hours on the phone and really got her into a better place. But right in the middle of the conversation, her husband grabbed the phone and said, "Are you charging her by the minute?" And I went, "No, absolutely not. This is what support group leaders do. This is what we're supposed to do. We're here for you." And so I want to educate you. I want to inform you. I want to answer any questions. I want to give hope to patients who are newly diagnosed. I want to help those patients who are struggling with symptoms. I want to help those what I call grizzled veterans, patients who have had IC for a very, very long time, and they're just not getting better. I want to share the story. Oh, Donna, thank you. Donna says you're my sister, and I worry about you. Thank you, honey. And I worry about all of you too. I want to share the story of one of my oldest IC friends. And she has had literally one of the most severe cases of IC. I mean, obviously, in 30 years, I've worked with, oh gosh, we worked with 200,000 patients a month on our website for many, many years before everything got spread out with social networking. So we've worked with really millions of patients over the years. And in all those patients that I've worked with, she's absolutely the worst. Really, absolutely one of the worst. Her pain, absolutely off the charts. Um, and she had done bladder therapies for many, many years, and she still continues to do bladder therapies, really with no success. And yet, she's a teacher. She loves children. She loves to teach. And she is my hero because she did things I don't think I could have ever done when my IC was very, very severe. And that is, she went to work anyway, despite very, very severe pain. She did bladder installations at work in between classes because she loves to teach. Loves to teach. So, in all of these years, she's seen a variety of IC specialists, variety of doctors, and they've all pretty much said you've got an incurable bladder disease. But of course, oh, oh, look at that! My foot just hit my chair. Hold on. That's so funny. Whenever I do that, whenever I suddenly go down, that's my foot hitting a lever on my chair. So anyway, doing IC therapies for decades, suffering with severe pain the entire time, eating pain meds the entire time. And then, of course, we now have phenotyping. So we now understand that really, for the great majority of us, it's really not a bladder disease. And research estimates, oh, there's a squirrel looking at me, 85% of IC patients are actually neuromuscular patients. That our bladder symptoms and our pelvic pain is a result of nerves and muscles as compared to a defect in the bladder wall. And so, she and I talk fairly consistently. And it's like, hey, bladder treatments aren't working for you. Have you had a pelvic floor assessment? No. In all this time, she had not had anybody look at her muscles. It's like, well, isn't this interesting? So here's something you've never explored, and we have to really try to understand why you're in such high levels of pain. So then she goes to pelvic floor, and she's so tight, if I remember correctly, they cannot even do a proper examination. Massively tight. There are some women who have what we call vaginismus. They have muscles so tight that they're just squeezing the urethra closed. They're squeezing the vagina and the rectum closed. But she finally found a doctor who said, you know what? Let's try some nerve blocks. And do you know what happened? She had a nerve block. And for the first time in 40 years, her pain went away. For 5 days, her pain went away. It was stunning because all of this time, everybody's going bladder, 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 bladder. But when we turn off a nerve, all of her pain goes away. And so she finally found a doctor who would consider the role of nerves and muscles. And that doctor finally said, you know what, let's just check out this nerve. And now they're doing different types of, they tried different types of nerve blocks. One worked, one didn't work. And she just had a nerve ablation, which is designed to kind of basically kill that nerve that's hurting so badly. We're waiting to see how that goes. But her story is really a story that should give every single one of us hope. Because after decades of suffering, after decades of trying bladder treatments with no effect, they finally realized it was a messed up nerve. Now, why that nerve is messed up and why those muscles are messed up, that's a whole nother story. In all likelihood, she suffered an injury in childhood, a trauma in childhood that made those muscles go very, very tight. That's usually what we see in patients who have vaginismus. Sometimes I was working with one patient who was jumping over a fire hydrant and think about the little point, the little round hard point at the top of the fire hydrant, right? She's jumping over the fire hydrant, landed on top of it. And it was such a bad injury, she was bleeding. This isn't the patient I'm talking to, this is another patient. So those childhood traumas. Another one I can think of who was kicked in the crotch badly. And still others who have had bike riding accidents, horse riding accidents, falling off of horses, things like that. And so, as Anne says, what happens when you have tight pelvic floor muscles? The legacy, see what makes the pelvic floor muscles so unique is that they're the only skeletal muscles in the human body that are just that also directly impact three major bodily functions. They will influence how you urinate, they will influence your vagina, and if you can have sex, of course, for men it's only two, but for women it's three, and they will absolutely influence your rectum. And if those muscles are tight, they squeeze them. And it's hard to get stuff through. My first diagnosis, so remember, my first symptoms began in 7th grade, the year that I broke my tailbone. And of course, we didn't know to look at that back then. We didn't know to look at broken tailbones back then. So they just thought, everybody just thought I had a bladder infection. I can still remember swallowing. They handed them to me at the doctor's office. I had to swallow 16 pills of antibiotics. 16. But then my official diagnosis was what we call a urethral stricture. A urethral stricture is, it means the urethra is restricted. It's narrowed. And honestly, it was like trying to pee through a needle. I can remember that. I can remember this really tiny little urine stream coming out because my urethra is so narrow. And so back then their answer was, well, let's just do a urethral dilation. And what they do is they stick a wand inside it, stretch it open. And by stretching it open, then you're allowing patients to be able to empty their bladder. But they never asked why. Why was everything constricted down there? Well, hello, it was my levator ani muscles from the broken tailbone. So if there's one thing that you should remember from me talking with you today, is number one, there is always hope. If you're not getting better, we have to figure out why. And we have to do phenotyping now. Now, everybody in the world, all the doctors in the world at the upper IC research level now completely admit there are distinct patient groups. For some of us, it's pelvic floor driven. Really, honestly, for most of us, it's pelvic floor driven. For some of us, it's driven by the central nervous system. We call that widespread pain. And then a very small population of us actually have a problem with the bladder wall, like a Hunner's lesion or estrogen atrophy. But if you've had a hydrodistension or a cystoscopy and they've looked in your bladder and your bladder looks good, then maybe it's not your bladder. If they can find no defect in your bladder wall, maybe it's not your bladder. My cystoscopies were completely normal. My hydrodistension was completely normal, and yet I had pain so severe I could barely walk. Now we know why. Ann says, is a spin bike at the gym a no-no? Hell yeah, absolutely. Spin bikes are terrible. You should not be using a spin bike because what that's doing is that's putting pressure directly up into your pelvic floor. And here, hold on. I have a perfect picture for that. All right, where's my book? Where is my favorite book? My favorite book in the world. Here it is. Okay. Okay. So for those of us who have problems with muscles and nerves, this is your book. This is the book you get. I want you to be able to walk into the doctor's office knowing the names of the muscles, where they're located, so that, or the physical therapist office, so that you can talk directly with them about where your pain is. So let's look at this picture real quick. These are the nerves, the vulvar pudendal nerve connection. Do you see all these nerves right here that are coming up and that are innervating this area right here? But this is also where a bicycle seat hits. So if you're sitting on a hard bicycle, you're sitting directly on nerves. You're sitting directly on muscles. Let me see if I can find this picture real quick. Here it is. See that bike seat right there? You see the nerves So here's the sacrum. Here's the nerves coming out of the sacrum. You've got nerves that come out of the left side, nerves that go out the right side. They curl down. And here's that bike seat. And that bike seat is sitting right on these major nerves. And then if you look at the skin, you've also got nerves that the front of the bike seat is sitting on. So sitting on a bicycle seat is a bad idea. Spinning is a bad idea. You can be on a recumbent bike. I don't have a problem with that. But a regular bicycle, not good. Judy says, what causes a weak urine stream? Well, a lot of different things can cause a weak urine stream, but we really want to look at the health of your muscles. Urination is about relaxation. You should be able to pee like a horse. You know, I call it pee envy. How many times have you gone to a public restroom and you're sitting on the toilet trying to urinate and somebody comes in next to you and they pee like a horse? And you're like going, how do you do that? That's crazy. I can't do that. Well, the reason why they can do that is because they have relaxed and normal pelvic floor muscles. The reason why we can't do that is because we have tight pelvic floor muscle. Urination is about relaxation. You sit on the toilet, a muscle relaxes, the sphincter opens, and you pee. But if you're stopping and starting, if you hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine, that tells me your muscles are tight. That's really how you can check in on a daily basis on how your muscles are doing. And that is by looking at how you pee. If you can pee easily, you're good. If you're stopping and starting, if it's a slow stream, it probably means that your muscles are a little bit tight. Anne says, my physical therapist told me to stop using my pelvic wand. Why? I don't know why. You have to ask her. Maybe you're being a little too aggressive. Maybe you're pushing something that you shouldn't be pushing. Hold on a sec. Anne said, so if everything comes out normal, is it pelvic floor? I think it's remember, you've got lots of different muscles. You've got muscles that go from front to back, left to right, low to high in your pelvis, right? They support the pelvic organs. And so there's no way for me to say perfectly that everything is normal. You have to have a proper pelvic floor assessment to get that done. And if you go to a physical therapist and they say you have good, healthy muscle tone and that you're not tight, then we have to go with that evidence and we have to assume that something else is going on, perhaps something like estrogen atrophy. You know, when I think about the groups of patients, when I think about the phenotypes of patients, the largest phenotype by far, pelvic floor. The second largest group really is going to be the estrogen atrophy patient. There are so many women who are on strong birth control that's put them into an early perimenopause, or they've had hysterectomy and they've lost their ovaries, or they're just getting older like me. That loss of estrogen is going to weaken the bladder wall. It weakens it because your bladder wall protects itself with a really nice thick coating of mucus. You know, your bladder's like your mouth. It's a hollow organ that's wet on the inside. But that wetness has a very, very, very important purpose. And that is it's a barrier, it protects everything. Unfortunately, that barrier is estrogen dependent. So when you're young and have lots and lots of estrogen, you got lots and lots of mucus, and your bladder's ability to defend itself is fantastic. But once you've lost that estrogen, now your bladder cannot make that mucus, which means your bladder's ability to defend itself is now compromised. So that cup of coffee you're drinking in your 40s, all of a sudden in your 50s bugs you. That doesn't mean you have a disease process going on. It means that you're probably dry. If your vulva's dry and your vagina's dry, so is your urethra, so is your bladder. Hello, Sue. Nice to see you. Jody says, how can I stop histamine mast cell explosion during sex? Well, normally a sex-induced flare is a pelvic floor flare. So what's so interesting, the difference between men and women who have pelvic floor dysfunction is for men, the moment of the worst pain is the moment they ejaculate. because that's when their muscles go, their muscles really tighten to help them ejaculate. And so for a man with pelvic pain, it's that moment of ejaculation that can sometimes feel like you're being stabbed with a knife up your penis. For a woman, our muscles are usually pretty good during that moment of orgasm. Our flares start about 6 hours afterwards. And that flare is going to last a good 18, 24 hours because in the female body, the pelvic floor muscles basically have this very gentle movement slash spasm after sex, which I think is all about helping an egg meet sperm. And so if you're somebody who flares with sex, what are we going to do? We're going to make sure, number one, you're using a ton of lube, because dry skin on dry skin hurt, that's going to be irritating. That absolutely is going to be very similar to a histamine reaction, or it could cause a histamine reaction. Dry skin on dry skin is not fun. So it's very important that you use like a lot of KY or whatever you're doing. And also, if you're super dry, you're actually potentially ripping skin. And that again could trigger a histamine reaction. It's kind of like a mosquito bite. Urine goes into the wound, or irritants go into the wound, and that's going to cause redness and swelling, which is a sign that histamines are involved. But usually that sex-induced flare is really going to be a pelvic floor flare, and the way we're going to treat that is with muscle relaxant like Flexeril or baclofen. We want to do a skeletal muscle relaxant, not a smooth muscle relaxant. The bladder itself, if you're having bladder spasms, you do a smooth muscle relaxant like ditropan, oxybutynin, Detrol. But those medicines don't work on skeletal muscles. So for your pelvic floor, you need a skeletal muscle relaxant, and that's going to be baclofen. Baclofen is kind of the first choice because it's not sedating. And Flexeril. Honestly, I couldn't take baclofen. It made my face itch. So I'm a Flexeril girl. And honestly, I do 1/4 of the lowest dose at bedtime fairly frequently because I'm really struggling with tight muscles right now. Tight pelvic floor muscles, but also very, very tight neck muscles. My neck is ridiculous right now. Kayleen says, I really get, and you guys, we're simulcasting right now. So when I look straight, I'm looking at Facebook. When I'm looking over here, I'm looking at YouTube. So I got questions coming in from both. And if I miss a question, please ask it again. Don't take it personally. It just means I missed it. And believe me, I missed stuff. Kayleen says, I get really weak streams for the first pee after a bladder instill. He also does double lidocaine. Well, that makes total sense, hon, because lidocaine numbs nerves. And so you're basically turned off the nerves that help you urinate. And so, of course, it might be a little bit more challenging to urinate after you have a bladder instill. That doesn't surprise me at all. Donna says, is there any research regarding how new nerve help with patients that have nerve pain when having a bowel movement, increase in vulvodynia issues as well, given an estrogen cream? Girl, I right now, because I'm serving on a committee that's creating new guidelines for male pelvic pain, I just went through not all, as much the PEA, palmitoyl ethanolamide research that I could find, because I'm trying to educate them, because I think we really need to add it, because in Europe, they've added PEA as a treatment for IC. And PEA is a simple over-the-counter supplement that calms nerves down. Anyway, so what was so interesting is I found that literally almost every overlapping condition to IC, the widespread pain, the IBS, the vulvodynia, the TMJ, the migraines, they all have their own PEA study showing success. And with no known drug interactions and very, 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 very few side effects, if any. So I'm putting that report together. I'm just waiting for one more piece, because I was told by my counterpart in Italy that PEA was added to the International Continence Society's guidelines for IC. And I want to read that to bring that to our American research team. Donna says, I take gabapentin, Flexeril, etc. My physical therapist thinks it may be a pinched nerve in my back. Um, I wouldn't ignore that. We're really seeing and studying more about nerve injuries and nerve traumas and where do nerves get compromised. And for some of us, nerves get compromised at the spinal cord. If you have a ruptured disc, if you've got a Tarlov cyst, that absolutely could be triggering some of these symptoms. Thus, Donna, it'd be really interesting maybe to consider having a nerve block. I mean, that's considered diagnostic anyway. It would be fascinating. Here, hold on one sec. Jody, hold that thought. I've never heard of that before. Let me scroll back up here real quick. And you guys, this is my breakfast and lunch, so. Okay. Hi, Sherry. Hi, Laura. Laura says, I have found that there is a strong link between tiredness and urine frequency and pelvic pain. I was told tiredness can't make it work. Now, isn't that interesting? I don't know if I understand the body mechanics for that. You guys, what do you think? Do you notice that you urinate more when you're tired? I don't think I've ever made that connection or that correlation. I mean, if you're I'm trying to think about, okay, so let's just say you're really, really tired and you're laying on your couch. And let's say you're in some pain, but not enough to get you off of the couch because you're so tired. But the pain is making your pelvic floor muscles get tight. And when your pelvic floor muscles get tight, that could trigger more frequency urgency. I mean, that's a guess. Laura, that's a very interesting correlation. Jody says, my flare after sex is 48 hours. Doesn't surprise me at all. And so for that after sex flare, this is where something like a vaginal Valium suppository is perfect. So that, after you have sex, couple hours after you have sex, if you just insert that vaginal Valium suppository, which will relax those pelvic floor muscles before they go into spasm, that's a good way to try to reduce, if not prevent, that after sex flare. Anne said, is a urodynamics test necessary? No. A urodynamics test is really kind of testing the health of the nerves in the bladder. So basically, when you have a urodynamics test, you're going to lay on a table and you're going to be catheterized and they're going to slowly fill your bladder with fluid and they're going to ask you, tell us when you first feel the need to pee. Tell us when you first feel the need to strongly pee. Tell us when you first feel some discomfort. Then tell us when you need pain or when you experience pain. And so if I remember, 2 guidelines ago and here in the US, they said absolutely not necessary for a diagnosis of IC. It is a snapshot of the health of the nerves in your bladder, though. I had it done. Wasn't the funnest thing in the world. Wasn't terrible either. I think when you have it, you just have to have a urologist. Before you start it, as you're laying on the table and you see the IV bag with fluid and they're getting ready to catheterize you, what I would just do is say, Doc, when I say stop, I need you to stop. I'm not making this up. If I'm in pain, if I'm in severe pain, I need you to respect that and I need you to stop. I do not want you to push it past that pain. So when I had it done, I had a fantastic urologist, Dr. Klein, who's now retired, who really listened to me. And he slowly filled my bladder. And then again, he said, tell me when you first feel the need to pee. And I'm like, okay, I feel it right now. He goes, okay, let's just do a little bit more. And he's like, okay, tell us when it first hurts. Okay, it hurts right now. And he stopped immediately. It's those doctors that push it that I think traumatize patients. And so I would just be very, very vocal and say, I need you to respect my pain. And if it hurts a lot, I want you to stop because it's your body. You're the boss. Jody says, my IC started 2 weeks after a date rape. Is there a correlation? Oh, Jody, honey, I'm so sorry. I am so, oh boy, could I go off right now. Women, my friends, my women, my female sisters, this is not a kind world to women. It's not. And I will tell you, my generation, virtually every single one of my friends have been raped. And I was rescued from a date rape in summer when I was uh, uh, 18 years old or 19 in Connecticut at a tennis camp. And I was rescued. And it shouldn't be this way. It shouldn't happen this way. I would encourage every single woman out there, especially if you have young daughters, to please put them into karate or taekwondo. Give them some skills so that they can defend themselves. Because so many of us have been traumatized and so many of us have been the victims of sexual violence. So Jody, I think the answer is that yes, because that was a trauma to your pelvic floor. The odds are that your pelvic floor sustained a bit of an injury, and you might have sustained some tissue injury too. And so it would be really good for you to go to a pelvic floor physical therapist and let them do an examination. Basically, when you go to a pelvic floor physical therapist at that first appointment, it's what we call an assessment. Their job is to just study muscles. So what they're going to do is have you walk up and down a hallway. They're going to see how you walk. They're going to measure your leg length. And I got a really interesting story about that. And then they're going to ask you to do a vaginal exam. You're not in stirrups. You're laying on a table. Your knees are slightly up. Super easy, not threatening at all. And they're going to be loved, have a little bit of KY, and they're going to insert their finger in your vagina. And all they're going to do is touch muscle groups. They're just looking for muscle tension. That's all. And if they find that muscle tension, that is what I call your hallelujah moment. So if they touch something in here that triggers your pain and discomfort, that's fantastic. It means they found it. And your immediate question is going to be, what are you touching right now that hurts so much? That's it. That's it. For me, it was my piriformis muscle on my left side. That's where the great majority of my pain was coming from. The hard part, though, for those of us who have been a victim of violence is we don't want anybody down there and we don't want anybody touching us down there. Physical therapists have been trained to be very kind and compassionate for anybody, men or women, who have been a victim of sexual violence. You just need to let them know, because then they understand that their job is to build trust. And they might not do a vaginal exam for several weeks. They just might do some external stuff first. But I will tell you that the reason why I'm sitting here today pain-free is because I did physical therapy after 30 years of doing bladder treatments. And physical therapy healed me. The vast majority of my symptoms are gone, and they've been gone for years. I have been sleeping all night long. Woo! I mean, wow. 2 nights ago, I slept 10 hours. Back in the old days, I was up every 30 minutes. And that is because we got my muscles healthy, that restored blood supply to my bladder, and my bladder started to heal. Now, let me tell you another interesting story. Hi, Angel. And Donna, maybe we can talk about that. Maybe. I was working with a patient on Friday who, let's see, also had IC symptoms for a good period of time. And she went to physical therapy, but she really didn't think the physical therapy helped her. She's still really, really struggling. But one of the most important questions you ask that physical therapist is, are my muscles responding to therapy, or are they always locking back down into tension. Because if your muscles are always locking back down into tension, like mine on my left side, that's when we need to look at bones. Because what puts pressure on muscles but bones? And so many of you have shared that you've had broken tailbones, a hip that's slightly rotated, a funky SI joint, a bad knee, bad feet. Her case was so incredibly interesting because her symptoms started in childhood. And it turned out she had polio in childhood. And she had one leg that was 2 inches longer than the other. That's huge. And so let me grab my model here real quick. Okay. So I want you to, so here her entire life, she has had one leg longer than the other. So when you walk, your hips are supposed to be level. Boom, 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 boom. That's a normal motion for walking, like this, right? She was like this. And so what is that angle doing to her muscles? Well, certainly over time, it's created a wear and tear injury. I think that the leg on the short side was probably carrying more weight and probably experiencing more force as she walked, and the leg on the tall side, the muscles on the tall side might have been stretched out a little bit. I've got another really good picture here that will show you what happens when, here, hold on. Okay. This is kind of similar, but it will show you how just a very minor problem with a bone can tweak your pelvic floor. Right? Okay. So here is a normal leg. So your shin bone is at a 90-degree angle to the ground, straight up, right? The forces when you walk go straight up. And then, of course, your femur has a slight angle. Whoops. It's so hard. I'm looking at it in a mirror. Your femur is at a slight angle. And if you look really closely, here is one of your pelvic floor muscles attached. Now, I want you to look at this side. Do you see how the muscles on this side are stretched out almost twice as far as the other one? This is healthy. This is not healthy. So why are the muscles stretched out on this side? Well, the one thing you can see is that the femur is at a greater angle. Why? Because the ankle is rolling in. She's got this, in this diagram, we've got somebody who's overpronating and the ankle is rolling in. And you immediately see that we're not at a right angle anymore. We're at an angle like this. And that gets magnified the higher and higher it goes until we have a really stretched out pelvic floor. Now, listen, when you're a kid, your body's very resilient. You're not going to feel that as a child. You're not going to feel that as a teen. You are going to start feeling that in your mid to late 20s and 30s. And that is something that Dr. Weiss talks about. He talks about what we call wear and tear injuries from basic body mechanics that they hit. I was working with a 30-year-old who, was really struggling with wear and tear. If you were an ex-athlete like me, you're going to be much more prone to having pelvic floor issues. Because we worked out often too much and we often damage things. So at least my SI problem is from the fact that I played tennis professionally. And also I obsessively ran up flights of stairs for 10 years. I did my workout throughout most of my 20s, well, probably from 18 to 27, was 100 flights of stairs a day. Then I would swim a mile or two. and then I would row 5 miles. That was my workout every day. I loved it. It was how I handled stress. I had no idea I was damaging my SI joint, and I did. I also damaged my feet badly. So, for those of us who are athletes, we're going to be much more prone to injuries. Also, Angel said I was trying to get in contact with you. Angel, honey, I had pneumonia. I have not been very visible for almost a month. I got COVID and then I got pneumonia. So, yeah. Yeah, and it was awful. And I was in the hospital. I ended up at the emergency room twice. The COVID got my lungs and then it got my heart. And so I was having heart issues. Thankfully they were pretty minor and and they should go away. So I got COVID tachycardia. So my heart, I couldn't calm my heart down, and usually in the middle of the night. So I just drove myself to the emergency room twice. Yeah. So, so anyway, Angel said I had my surgery and had to get 3 catheters put in. My sling was too tight, so the last one is in my stomach now. Girl, what? Oh, okay. So obviously, Angel had a prolapse, and they had to go in. Angel, tell me if I'm wrong. She had a prolapse, and they had to surgically repair it, and they surgically repaired it with a sling procedure. But a sling procedure basically, so remember, your pelvic floor muscles are basically like this along the bone, right? So here, I can do it from the backwards. So here are pelvic floor muscles here and here. And you notice that when you sit down, there's no bony structures here. The muscles are on the inside of these bones. So if these muscles right here get very, very weak, you have a prolapse and things start to fall out. Things start to fall down. Your bladder can fall through your vagina. Your uterus can fall. All sorts of bad things can happen when these muscles get very, very tight. So Angel had that surgically repaired. And the hardest part about having a prolapse repair is that the doctor has to rely on their experience and their sense of touch to determine how tight those muscles should be. Because the muscles should not be really, really tight. The muscles have to be fairly distressed. I don't know what the right word is. The muscles have to be healthy. If they're tight, as Angel said, she could not urinate. So, Angel, I was working with another patient, same exact thing happened. It was just way too tight. And yours was even tighter than hers because she could urinate, but barely. But yours were so tight they couldn't. So what you normally have to do is go in and surgically fix that and release it. So have they talked about doing that for you, hun? How is your OBGYN proposed fixing this tightness? Because they can surgically fix it. And you have to be the squeaky wheel, hun. You got to be the squeaky wheel. If it feels bad, if you're in pain every day, you got to tell them you're in pain every day and they've got to fix it. I'm not a fan of it'll loosen over time. Listen, if it's going to take 5 years to loosen, that's 5 years of pain for you. That's 5 years of nervous system upregulation. It's not worth it. They need to work to try to fix it, in my opinion. Oh, they did it on Tuesday. So wait, they did the first surgery or did they go in and repair it on Tuesday? Rachel said, my symptoms have returned since I had my colonoscopy. Could the prep have caused that? Rachel, I will tell you that it's really rare that we get anybody reacting to preps. It depends upon the type of prep you used. So if you did like a heavy salt prep, then that could certainly irritate the bladder wall. It's also more likely that you're having a pelvic floor flare, because think about it. I mean, haven't you guys noticed? I mean, this was something I noticed in my 20s, because in my 20s I had really, really bad IBS. And so I would eat a salad and 30 minutes later I'd have diarrhea, really bad diarrhea. I mean, like really painful. And as the bowel is spasming and the pelvic floor spasms, all of a sudden you can't pee. And I finally figured out that my muscles were so tight from the diarrhea that I was just going to have to wait like 15 minutes for the muscles to relax. At that point in time, I would then urinate. So think about the prep. I mean, it is the what's your quintessential? What's the right word? Quintessential. I can't pronounce it. The quintessent. The quintessent. I'm not sure if that's the right word. Anyway, it is the ultimate trigger for pelvic floor spasms and bowel spasms is doing a prep. And so I would put money that you're having a pelvic floor flare. When did you have your colonoscopy though? Angel said they did her first surgery on February 19th. They did the repair surgery last Tuesday. Okay, and you're better? Are you better now, hon? I hope you're better, girl. I'm so sorry. All right, let's come back to Facebook here. Sue says, I discovered something interesting. I was having a lot of restless nights because my memory foam mattress was making me too warm. The new mattress is much firmer without memory foam. I think the firmer mattress is better for my back, and I've been waking up with less pelvic floor spasms. It's only been a week, but I was only expecting to feel less warm. We'll see what happens. Yeah, I need to get a new mattress, and I'm gonna get a bed that I'm gonna get an electrical bed because I've been sleeping in a recliner for 4 years now. 5 years? And I sleep in a recliner because if I lay on one side, my jaw starts to dislocate. It's a long story. It's a long, long story. It all starts when I got rear-ended and got really, really bad whiplash in my 20s. But all the work that I do on the computer just exacerbates it badly. So my muscles are so tight on this side. And I have giant trigger points on this side too. Like there's one right there it's really working on. It's like, you see that? This trigger point is like that big on the side of my neck from that damn car accident. So if my neck gets super, super tight, it squeezes this side of my jaw, which forces open this side of my jaw. TMJ sucks. So anyway, I can't sleep flat on my back because my jaw dislocates or starts to. Life. So anyway, I'm gonna buy a new electrical bed. And thank you for pointing out that the memory foam was making you too warm. I think I can sleep in a bed that will come up like that. I'm gonna try because I miss sleeping in a bed. But having your jaw dislocate, it's awful. It's awful. I hate it. Val says, "What can explain the pain that gets worse when sitting? I tried baclofen for a week and it didn't reduce the pain." Honey, and Val, if you're still here, and I'm sorry for taking so long to answer your question, the pain when sitting is mechanical pain. It means that when you're sitting on a nerve. When you stand up, you're not sitting on the nerve. So of course the muscle relaxant wouldn't work it because it's actually body mechanics. When you're sitting down, you're putting pressure on a nerve. When you stand up, it gets better. That's what we call pudendal neuralgia. That's it, the IC phenotype 4. So anytime your symptoms are positional in nature, we have to look at body mechanics. Wendy says, I'm really struggling a week after having Botox injections. Wendy, are you struggling to urinate? That's a common side effect of Botox is it accidentally numbs the nerve which helps you urinate. All right. Um, and please know that Facebook doesn't let me scroll back. And so if you asked a question and I missed it, please ask it again. Don't take it personally. Anne says, what does nocturia come from? Nocturia usually will come, what can come from a couple of things. It can come from a little bit of kidney failure where your body is getting rid of more liquid at night. But it can also come in the IC patient population. Nocturia is usually a direct reflection of something you've eaten during that day that's irritated your bladder wall. And you can handle it because you got distractions during the day, but there are no distractions at night. You're laying flat on your back at night and you feel everything. And that's when you feel the sensation of needing to urinate more frequently. So that nighttime urination really is often a direct reflection of something that's happened during the day. Sue says, my neurologist wants to put me on Topamax because I get migraines and the regular medication causes rebound. My concern is when reading the side effects, it can cause problems with bladder issues and a whole other list of side effects. Is there any research? People with sensitive nerves and painful bladder nerves and this medication, not that I'm aware of. You're going to have to go to the National Library of Medicine. Sue, if you hold tight towards the end of the meeting, remind me and we can, I can research it for you. Okay. Not a problem. Amanda says, I've been putting a little baking soda in my coffee every morning for a month with no flare yet. What are your thoughts? The problem with baking soda is it's sodium and sodium will raise your blood pressure. So it's usually better to do pre-leaf instead. It's better to do a calcium-based product rather than a sodium-based product. Also, please remember and understand that as women get older, our ability to process salt changes and we become more salt sensitive. And that is why 50% of women who are menopausal have high blood pressure. Me too. Oh God, that's a whole nother story. Let's see. Cassie said, so I tried installations, a mixture with heparin, lidocaine, sodium bicarbonate, and solumedrol. I only did 3 because they made my frequency urgency so much worse. But after my urologist said that it should have worked because I had IC, she told me to see a psychiatrist and pain management. Cassidy, God damn it. They should have never said that to you. And I'm sorry for swearing, but that really pisses me off. You have pain. You have discomfort. How dare they tell you that it's all in your head? How dare they? You want to know why? Because in 1952, 2 arrogant pricks of doctors published a paper of a young woman with IC in which they declared it was unexpressed anger manifested in the pelvis. And from 1952, literally until 1990, most medical schools taught that IC was mental and emotional. But now we know, of course, it's not. We've invested more than $100 million into IC research. We now very clearly understand that IC is essentially a physical injury to the pelvis. It's not a disease in most of it. It's an injury or trauma for most of us. So I guess two pieces of feedback for you. Number one is sometimes bladder installations hurt if you're sensitive to an ingredient. And the ingredient that most patients can be sensitive to, well, not most, for the patients who flare after a rescue, it's the lidocaine. And so they would normally switch it over to Marcaine to see if Marcaine was more tolerable. So you were probably just having a reaction to the lidocaine. But what I want to know, Cassidy, is have you been phenotyped and have you had a pelvic floor assessment? Because we need to know what's going on with your pelvic floor. And also, have they looked in your bladder? Very important to if your pain is very, very high, you don't want them to guess. You need facts. And there comes a point in time where it's perfectly reasonable to have somebody look in your bladder with a cystoscope just to see if there's anything funky going on in there. Could you have a bladder stone floating around in your bladder? Is there something else going on in your bladder or a Hunner's lesion? So what I want to know, Cassidy, is number one, have you had a pelvic floor assessment? Number two, has anybody looked in your bladder? And if yes, what did they find? If you had a normal, healthy bladder, that means that it's probably not your bladder. It's probably your pelvic floor and nerves or something similar. Mary says, I started experiencing pudendal nerve pain after my C-section 7 years ago. I've been brushed off by doctors. What do you suggest to ease the nerve pain? My bladder holds 1 to 2 ounces max. Could the nerve pain be a reason why I do have Hunner's lesions? So, um, Mary, you are potentially what we call a surgical injury patient. That something happened during that C-section which traumatized a nerve. You could have scar tissue from the C-section that's compressing the nerve. You could have adhesion. Well, that's what an adhesion is. Um, One of the things we want to know is that scar tissue sensitive to touch? Is your incision sensitive to touch? If it is, you can do things like rolling to try to get all of that to calm down, to try to release some of that scar tissue. Um, uh, a nerve block might be very, very interesting to see if that would help. What I don't understand is your bladder capacity. Why is your bladder capacity so small? A couple of things come to mind. Sometimes when you have pelvic surgery, they accidentally cut into the bladder, whether it's a hysterectomy or a C-section. And especially with a C-section, because if you're laying flat on your back, your bladder is in front of your vagina. And so as they're making that incision, there's always a potential chance of them slicing open your bladder. If you were sent home with a catheter, if you're ever sent home with a catheter after a hydrodistension or surgery, what that means is that your bladder wall was damaged in some way. And you have the catheter for a week or two to allow the bladder a chance to heal. So concept number one is that your bladder was directly injured during the C-section. Concept number two is you could have sustained a muscle injury or a nerve injury during the C-section. But you also have Hunner's lesions. And so that opens up kind of another very, very interesting can of worms. Because a lesion is basically a wound on the bladder wall. It is an open wound. I have pictures, but I've been redoing my office. Here, hold on. Let me see. Where did I put them? Ah, here they are. So a Hunner's lesion looks like, I love show and tell. I love showing these pictures. Okay. So these are pictures of Hunner's lesions. I mean, this one right here, you can see that's a ginormous Hunner's lesion right there. Hunner's lesion, this is a classic presentation right here. It has a center red spot, and then there are arms that radiate out from the red spot. So that right there, absolutely classic Hunner's lesion. Okay. And only about 5 to 10% of IC patients have lesions. That's it. The rest of us, we have a normal bladder. Obviously, we're very different. We've been trying to, and there's a steady move to separate Hunner's lesions into their own research group, because there are key differences. When you biopsy a lesion, you find massive inflammation. Massive inflammation. There is a biological war happening in the middle of that lesion. Why? Why? Well, we've got two fundamental theories. Theory number one is that it's actually a virus. That we have good research now, multiple studies, including a study from the National Institutes of Health, which has identified something called the polyomavirus in the urine of patients with Hunner's lesions. The polyomavirus is a virus we all have. It is a normal part of the human biome, the urinary biome. It gets turned on when a patient is immune compromised. And so the patients who are the most prone to viral infections in the bladder itself are going to be patients who are on immune suppression drugs, like for kidney transplant. You're trying to prevent the rejection of organs. Patients with HIV and AIDS, radiation, hemorrhagic cystitis was very common 25 years ago, 30 years ago, as we were dealing with the AIDS crisis, not so much now. So again, concept number one is that it's either the polyomavirus or the Epstein-Barr virus. But the second theory about a Hunner's lesion is that it is massive neuroinflammation. That a nerve in that area is extremely inflamed. And inflamed nerves release something called substance P, which damages tissue. Very, very, very damaging to tissue. So we had and also Hunner's lesions can come and go. That's also something else that's very interesting. I was working with a patient last week who was told she had Hunner's lesions, went to another doctor, looked in her bladder, said, nope, you got a perfect bladder. So lesions have the potential of coming and going. Sometimes more grow back. Sometimes they just disappear forever. So 2 years ago, a very, very interesting case study came out. And it was of a woman who had very severe Hunner's lesions, and she also had a very severe prolapse. Her prolapse was so bad she couldn't urinate well, kind of like Angel. So they made the decision to go in and repair the prolapse first so that she could urinate. And when they went in, they made a remarkable discovery that her uterus was backwards. The front of her uterus was facing backwards, and the back of her uterus was facing frontwards. Why? Because one of the ligaments that normally holds the uterus in place had broken. And so her uterus was free swinging like this. That's what we call a strangulation injury. When anytime tissues start to twist like that, then they become very, very severe. It can be very common in men, as I think seminal vesicles twist, something like that. Anyway, so she had a strangulation injury. So what they did is they restored the proper position of her uterus, reattached it so it wouldn't move, and something absolutely remarkable happened, that her Hunner's lesions healed completely. She is considered a complete and total cure. So that's a very good example of neuroinflammation. So I have to wonder if the surgery just really, really traumatized nerves down there also. What I would suggest trying, now remember, I'm not a doctor. I can't give you medical advice. My job is to educate and inform. Would be something with PEA in it, palmitoyl ethanolamide, which we know calms nerves down. We have much, much research supporting that. And so in the IC Network shop, this is called Piora. In 2019, the European PEA researchers did a study, and that study found that 87% of IC patients reported a significant reduction in their pain and discomfort with a supplement that was very similar to this. They used something available in Europe. We don't have that here. And so a Natural Approach Nutrition, a company that has been very, very dynamically involved with IC, took that research and created a similar supplement here. So we have this in the ICN shop. We had so many research studies for acute pain, chronic pain, surgical pain, IC, chronic fatigue, fibromyalgia, burning mouth syndrome, shingles, showing success with PEA. And so this would be something that I would look up palmitoyl You can get the scientific name on our website. You can go in the shop, go to icnetwork.org and click on our shop, and it's right on the front page. Copy the scientific name and then Google it so that you can look at the research. A lot of people ask me what I do. Well, my phenotype is I have a healthy bladder wall. I don't have to do anything for my bladder wall. I've got muscles that are constantly tight, and I have extremely sensitive nerves. And so I take the PEA for my nerves, for just calming my entire central nervous system down. And I personally love it. I don't take it all the time. I stop and start frequently. And for me, it's what we call durable, that if I can stop it for a month and I still feel good. And then once I feel like my nerves are getting a little bit more irritated, my skin is getting more irritated, I just start it back up. And it's cheap. It's under $30. So PEA, fascinating. Again, I was talking with my counterpart in Italy, who actually was one of the researchers of the ICPEA study. And she said that PEA has become a cornerstone, a very, very important part of their IC therapy in Europe. All right. Sue says, I always get a bad flare for a few weeks after Botox injections in my pelvic floor because they do bruise the muscles and then it improves even though you're in a flare. Just try not to curl up in a ball. Thank you, Sue. That's great. Jody says, in 12 years, I've only had 2 flares. I'm pain-free. Love it, Jody. Sherry says, back in the 90s, I had the most pain experience ever when my doctor did not stop during the urine fill test. I almost passed out. He said he wasn't going to stop because I could not possibly feel pain yet. He said my bladder should be much larger. Ugh, every single IV drop was excruciating, but my bladder was indeed much smaller. I will not ever do that again. Exactly. I had the exact same thing happen to me, Sherry, and I got the doctor fired. The radiologist who did the test, it was avoiding cystogram, refused to read the notes from the urologist. She got her ass fired. Lori says, can SI joint dysfunction cause IC? SI joint dysfunction will cause very tight pelvic floor muscles, which will cause bladder pain. Chloe said, will PEA you sell for the bladder help with back pain too? Yes, there is research that shows that it helps with lots of different types of pain. Absolutely worth a shot, in my opinion. Robbie says, last Friday I had a cystoscopy and 500 lesion cauterized. Woo, Betty. I'm now pain-free. Yes. Why did my old urologist not cauterize these in my last cystoscopy in May? Thinking about calling my lawyer. Am I being reasonable? One of the things that I say, or that I've written on the IC Network website in our area about hydrodistension with cystoscopies, is before you have it done, you always ask the doctor, what are your plans if you find a lesion? Will you treat it? Because lesions should be treated when they're found. If you don't treat it when you're found, you're condemning that patient to intense pain for months, if not years. When doctors say they have no plans, what that usually means is they lack the equipment to treat it. And that's a shame, because the IC guidelines going back over a decade have said very, very specifically, if you suspect lesions, do the hydrodistension and treat them. And it's a great tragedy when lesions have not been treated, because patients suffer and you suffered. Is it worth calling a lawyer? You know, it would be interesting to have a conversation with him, maybe. Did they ignore standard of care? Yes, I think they did. The national guidelines from the American Urology Association are very clear that Hunner's lesions should be treated with lesion-specific therapy. That's a triamcinolone injection or cauterization. We have new research showing hyperbaric oxygen can be found. Of course, now they're testing antivirals now that we know that viruses can also potentially cause lesions. So did he ignore standard of care? In my opinion, he did, but I'm not an attorney. And as somebody who was in a lawsuit for 5 years, I discourage anybody from going that route unless you were physically harmed. because the stress is surreal. The stress is so do not ever, ever, ever think that a lawsuit is easy. The only time I've been fired was by my employer when my IC started and I was out on disability leave waiting for surgery. And they only fired the 2 patients out on disability. And you damn well bet I fought back. I filed a grievance, they ignored it. I filed a National Labor Relations Board complaint. I filed a state complaint. I filed a federal complaint. That took 2 years. In the end, I got a letter saying I could sue. I sued. My attorney said it was $1 million case. My attorney declared bankruptcy, didn't tell me. They told the bankruptcy court my case was worth nothing. The attorney just used my money to pay off his bankruptcy. And in the end, I got $75,000, which I repaid to my parents because I borrowed the money from them because I couldn't work. So after 5 years of intense trauma, I mean, I was in deposition longer than OJ. I had an attorney accuse me in deposition that the reason I had to pee so much is because I was drinking too much water. Were they worth 5 years of my life? Hell no. Absolutely not. I really regret it. I do not see any value in doing the exception to that is going to be something like for those patients who have been harmed by medications like Elmiron causing retinal disease. I support that. But you just have to understand that there is a massive physical and emotional toll. And in the last 6 months of my case, I was so worried that I would not be able to pay my parents back because back then I lived with terrible pain every day and I could not work. That I was kind of suicidal. And it was, I mean, I was really going in that direction because I felt like I'd harmed my parents. And thankfully, we got it settled. I got screwed in the end. I even tried to pass a new law in the state of California requiring that attorneys inform patients when inform their clients when they go bankrupt. I wrote a law with my local state senator, and I lost out to the Hollywood Bar Association. The Hollywood Bar Association protested my law, and my law was not written into law. So just be serious. Gotta understand, it's difficult, and I was pissed off in the end. I was more angry at my first attorney than I was at my employer at that point in time. Rebecca says, I have estrogen atrophy. My cream is becoming less effective. Been flaring bad for a month. I follow a strict diet. Any suggestions? Rebecca, anytime you flare seriously like that, we want to make sure we rule out UTI. And you need to have a doctor look at your skin. You just may need a little bit more estrogen. But remember, other things can cause it too. Other things can be a challenge also, like have you hurt your muscles? Perla says, can adenomyosis trigger IC? Adenomyosis can certainly trigger pelvic pain and potentially some bladder pain. Mary says, I'm selecting a bowel prep for colonoscopy. And here, hold on. And guys, I want to remind you, we have 2 fabulous clinical trials right now that are looking for patients to participate. If you go on over to the IC Network website, they're right on the front page. We have one clinical trial that's testing a new foam to turn off bladder pain. That's very, very exciting. And then we have another clinical trial too that is working on IC symptoms. This is a way for you to get free healthcare working with the best doctors in the world. And it's a chance for you to get into an office that might have been closed for you and they don't charge you. So if you're interested in clinical trials, come on over to icnetwork.org. Just look at the front page. You'll find it. Okay, so Facebook just scrolled me down, and I know I missed some stuff there. I'm so sorry. Ask the question again. Wendy said, and it's painful too, gas pain, but I can't see what was before that. Donna says, I've learned so much from you in the IC network. Why do doctors tell you so little? They just don't have the time, hun. That's why we have support groups. Cassidy said, I have some lesions and inflammation. My previous urologist told me that my bladder is so messed up that it doesn't match up with my age. Cassidy, I would love to phenotype you. I'd love to ask you more questions. Um, number one, how old were you when this all began? And if you had lesions, have they treated them? And do you have a history of mono or Epstein-Barr? Wendy says they do a pudendal nerve block. I read that some doctors do it without anesthesia, so you can feel the difference. I've had 2 nerve blocks without anesthesia. They weren't that bad. Mary said, I have a cystoscopy next week. I have Hunner's lesions as well. Good luck, Mary. Make sure that they have a plan for treating them. I saw somebody saying that they were going to have a colonoscopy and they needed the prep. I have a blog on our website that goes over the different preps. The most common prep that seems to be the most bladder friendly is a Miralax prep. And that's basically 4 biscotals at 5 o'clock the night before, pills that just get things moving. And then you dump a half of a Miralax bottle into a tub of water or Gatorade. Can't be orange or pink. It's got to be green, white, clear, or purple or blue. Not purple, blue. The only thing I would recommend is get 2 separate flavors because getting that second bottle down is a little bit rough. It becomes very cloying, but that's what I did when I did my colonoscopy was the Miralax prep. Heather says, seems like we're hearing more about Hunner's lesions. Jill, I have horrible pain in my left back hip and groin on the left side. It's horrible when I sit and gets worse when I walk too far. What is causing this? Girl, that's easy. You've got a hip problem. You got a neuromuscular disorder. Hunner's lesions don't cause pain in your back hip and groin on the left side. You've got something going on with your hip or your muscles or your SI joint. You need to go have a proper consult with an orthopedic surgeon or a physiatrist. That's not your bladder. Wendy says, it's possible that tight pelvic floor caused Hunner's lesions. I had them before, but my last cystoscopy in 23 showed only irritation. Fantastic. Sue says, anybody doing the new trial for the foam for pain, even though you may not know if you're getting it? I'm still considering doing the study, but I'm waiting for the next session because they won't allow you to treat your pain. Sue, I talked with them this week. And Mary, if you're still here, one of the studies is changing the age up to 75. Yes, so you can do it. And they're also changing the entry requirements. I don't have them yet. I'm supposed to be they have to send it to me so that I can send out a blast email about that clinical trial. So you can, for those of you who are on my mailing list, I will probably be doing a clinical trial announcement this week with some updates. Michelle says, is it possible for a retroverted uterus to cause urgency? Had a urologist tell me she saw a dent on my bladder from the uterus pressing on it and recommended hysterectomy. Yeah, certainly. Something kind of similar to that is a fibroid. If you have a fibroid are tumors in the uterine wall. Sometimes the tumor goes inwards towards the inside of your uterus. Sometimes the tumors go outward. And if you have a fibroid tumor on the front of your uterus that is pushing into your bladder, that's going to cause bladder pain and bladder symptoms. And we have research that shows that when you remove it, the bladder calms down and the pain goes away. Fibroid tumors are a beast. I did a big blog on it on the IC Network website with a bunch of pictures, or it might have been in our magazine. So a couple years ago. Sue, they're changing entry requirements, just so you know. So hopefully I will have them this week. Donna said, does PEA have side effects for anyone? Very, very rare to have side effects. Most of the studies show absolutely no side effects. IC study showed no side effects. I've had no side effects from it, and I'm super side effect prone. But you won't know until you try it. I would just encourage you to take a single dose and wait 24 hours and see how you feel. But the studies, the one thing that the researchers say is it's really quite remarkable how gentle it is and how non-traumatic it is, or doesn't seem to trigger any serious side effects. I think I had one person say they got a headache from it, maybe, but the studies just don't support that. Donna says, "What's the best time to take PEA?" I take mine at night. Um, Jody said PA 500, found it on Amazon for 39. If you get it from the IC Network website, it's cheaper. Please get it from us. Get it from us. It's cheaper. Oh, you guys, please get it from us. Oh, it's so frustrating when that happens. And I have to drink for my throat, guys, just recovering from all this COVID, so bear with me. Mary says, "My lesions were treated several times, they come back." Mary, it really makes me think you've got an active and viral infection going on down there. Chloe said, "Extremely hard to get a doctor. Finder fired. My doctor caused death of my cousin and he was untouchable. They hired a top lawyer in LA and they couldn't even get his license revoked." Yeah, it's pretty tricky. And then if you've got, really clear malpractice, finding another doctor to testify against him is very, very difficult. And yet there is good news, and that is, according to the court records, the majority of IC patients who have been in the lawsuits for the Elmiron pigmentary maculopathy, they're all getting settlements now. The question is how much and how much are you willing to accept? I personally think that for anybody who's got eye issues from Elmiron, they need lifetime eye care. Absolutely lifetime eye care. That would be my hard and fast. If you want me to settle this case, you're going to give me a lifetime care of my eyes because your medication did this to my eyes. Sue said, "On the PEA topic, I noticed I have less IBS when I take PEA, less constipation." Yeah, Sue, I was just going through the bowel studies. We know they have a couple of bowel studies, what PEA does to the bowel. And one of the things that PEA does is reduce that the motility, out of control motility in the bowel for patients who have kind of diarrhea from IBS. Jody says you got 300,000 from your Elmiron case. Jody, congratulations, hon. I gotta say, listen, that's probably the single most important story I did because I'm the person who told patients about the Elmiron eye issue. That was me. And I can still remember it was a Labor Day, and geek that I was going through new research for IC when I found a letter to the editor from the researchers at the Emory Eye Institutes to the Journal of Urology, in which they said they believed that they'd found a new retinal disease associated with the use of Elmiron. And I read it, and I was sitting right here, guys. I mean, sitting right here, reading it. And I went, "What the hell? How is that even possible?" So I went and bought the eye article from the Journal of Ophthalmology, which was their first case series, which I have. I've shown it many times in stream. And then, I had a decision to make, and that is, do I share this new research with IC patients or do I sit on it? And I believe in informed consent. I believe that patients should have the opportunity to know that the medication that they're taking could be damaging. And so what I did is I emailed the top IC doctors in the country and said, "Are you aware of this?" I said, "Let's credibility check it. Let's do a survey. I got 30,000 patients right now. I can email and ask them to fill it out." And one of those doctors helped me do a research study. I now have 2,000 patients in that research study. And I sent out that email that changed the IC world. And believe me, I knew that it was dangerous for me and it was going to change lives. And yet, 20 minutes after I sent out that email, I had my first phone call from a patient who said, "Oh my God, now we know why I'm going blind. Thank you." An hour after that, I got another phone call from a young woman who took Elmiron during a pregnancy, and her child was born with eye disease. And she was crying and said, "Did the Elmiron affect my baby?" And I said, "I don't know." That was probably the single most important decision I've made in my job. And I'm still appalled that the other IC group has barely talked about it, because you deserve the right to know if a medication is harmful. Interestingly, the researchers at the MRI Institute also made another rather remarkable discovery that many of the patients who had the eye problems also had inflammatory bowel disease. And they published a paper on that now, that they believe that also. I mean, we all knew that Elmiron had the potential to cause diarrhea. And the idea back then was that it was from the capsule. So they just said, tell patients to take it out of the capsule. I can still remember talking to patients back in the 2000s who were struggling with very severe diarrhea. Now we know that Elmiron actually can change the structure of the cells lining the bowel, creating inflammatory bowel disease. And some patients have had to have their bowels removed. They have colectomies. So, and I got subpoenaed. The attorneys for Elmiron wanted everything I'd ever written on Elmiron. They wanted all the research. They wanted every patient communication I'd ever done. Cost me $15,000, of which I will not get back. It was worth it. It was worth it. So, never thought I'd see my name on a federal subpoena. And it was there 2 years ago. It was brutal. You know, you can't ignore a federal subpoena, you go to jail. It was pretty scary, but anyway, I'm glad you had your success. Amy says, "Just joining, what is PEA?" PEA is palmitoyl ethanolamide. Palmitoyl ethanolamide. PEA has been studied extensively in Europe for acute pain, chronic pain, surgical pain, etc. It's just dozens and dozens of studies. In 2019, the European researchers did an IC study with PEA. 87% of IC patients reported a significant reduction in their pain and symptoms with this combination of PEA and resveratrol. They used a formula that was created in Europe, not available here. And so I took that study to Natural Approach Nutrition, a company that makes bladder builder, said, "Hey, can you give us something for America that's similar to that?" And they created Peora. And this is in the IC Network shop right now. We've had it for 3 years now. And it's just been remarkably successful for many. So worth a shot. With respect to phenotypes, especially for patients who are in the widespread pain phenotype. Wendy said, "I just lost my job for being out under unpaid medical leave for a year now because my employer didn't approve I'm about to apply for disability. I have no other choice." Wendy, girl, I've been there, honey. I've been there. Cassidy said she was 13 when it started. The lesions were burned during my hydrodistension last February. No mono. Kayleen says, "I'm sorry for switching platforms." It's okay, honey. Could my bed be causing all of my pelvic and hip pain? Possible. Amy says, my husband is a GI nurse. Sitting here, he says, no biscodal. Talk to your doctor. Okay. Well, I mean, I had mine 10 years ago, and we have new stuff now. So thank you. Thank you for sharing. Robbie says, thank you so much for recommending Dr. Robert Evans. He's the one that fixed my lesions. I even had spasms on the way to the hospital trying to pee by the side of the road. It was awful. So glad to be better. Mary said she's having a cystoscopy on March 20th and a colonoscopy on March 22nd. Girl, on March 23rd, you get to celebrate. I am so impressed with you that you're just getting her done. You're getting her done. Good job. Amy says, I'm having my millionth hydrodistension next week. They give me relief for 3 to 6 months, but it's no picnic. You know, Amy, obviously, the hydrodistensions are really not working because your pain comes back. So it's not giving you long-term relief. The reason why you feel better when you have a hydrodistension is because they break the nerves in the bladder wall. When you stretch the bladder, I mean, the bladder is amazing because it's like a balloon. It gets big and small and big and small and big and small. And inside the bladder wall, there's a lot of structures and there's a lot of nerves. What happens when you stretch it is you actually break the nerves which are causing your symptoms. So you're getting a false sense of feeling better. But the problem is the nerves always grow back. And sometimes more nerves grow back than you had originally. So today, I mean, that's something that they did 20 years ago. Today, rather than chasing the symptoms, we're doing something called phenotyping to try to define and identify the underlying cause of your symptoms so that we can treat that. Because having hydrodistensions over and over and over, number one, there's always risk with anesthetics. It's expensive as hell. And if we can find the underlying cause and fix the underlying cause so that you don't need to have those symptoms, that's what we want to do. So sometimes, you guys, when we do these meetings, we go into Zoom afterwards, because if anybody wants to be phenotyped or they want to talk directly to me, we can do that. So if anybody wants to stick around, we can certainly do that. Because Amy, I would really love to try to phenotype you, to try to identify what the underlying cause is. It'd be fascinating. Jody said, took 5 years to finish the lawsuit. I went to my ophthalmologist for a non-related issue. It was found by mistake. I'm so glad they found it. Well, I mean, I'm sorry they found it, but I'm so glad that they identified it early. Robbie says, there's PEA and bladder builder. My doctor thought it was redundant to take it in addition to the bladder builder, which works great. Good. Kayleen said, I'm about to throw my hands up and apply for disability. I have a hernia that is sitting and causing pain on anything it can touch. Specialists don't care to listen, let alone lead me into the right direction. Well, Kayleen, girl, you got to embrace your warriors, your warrior spirit right now. I don't want you to give up and go out on disability, because I want you to have a life. I want you to be able to work. I want you to be able to have your family and have your kids. And if you give up and don't get that hernia treated, that's a real compromise. You got to embrace your warrior, inner warrior here. Emily says, I was diagnosed with IC last May. The surgeon noted that there were signs of IC. I've been prescribed amitriptyline and Myrbetriq. Since I met the deductible, the Myrbetriq didn't have a copay. And you can no longer afford it because it's over $1,000. Does Myrbetriq help to keep the pain at bay, or is it just for OAB? I believe I got this from the Epstein virus. Also have fibromyalgia. Since a Myrbetriq is no longer an option, is it necessary or does it make a difference with the hot lava pain? I do watch my food and drink. I take Preleaf when I find it. I go to the urologist in April for checkup. Is there any medicine I should request? So, Emily, you too need to be phenotyped, honey. So, Myrbetriq, okay. We go back 20 years. Everybody believed IC was a bladder disease, and the treatment of choice were bladder antispasmodics and Elmiron. So back then, you were usually given an antidepressant, you were given Elmiron, and if you had bladder spasms, you were given ditropan or Detrol, also known as oxybutynin. And it just didn't work for a lot of patients, myself included. In that time, we have learned that anticholinergic medications, the amitriptylines, the oxybutynins, the Detrols, the ditropans, have a very strong correlation to cognitive decline. And that research has been done with tens of thousands of patients now. I think the first big study was in Europe. The more anticholinergics you take on a daily basis, the greater your risk of dementia and even potentially Alzheimer's. And so 5 to 7 years ago, as this research came out, they started cutting way back on those prescriptions. And the advantage of Myrbetriq is that it has the potential of controlling some frequency urgency, but it's not an anticholinergic. So it's much safer in the long run to patients who take it. But I think it was Dr. Robert Evans. I think I was talking with him back then. He said the challenge is that Myrbetriq is just very, very expensive, and that it's a shame that the insurance companies would rather give you a medication that could cause dementia than give you the medications that won't. That's one of the fundamental flaws with healthcare right now. And that is why we need very, very strong legislation between our government and drug companies to get them to negotiate fair prices. If you want affordable meds, vote blue. That's all I'm going to say. Okay, so the other challenge we have here, Emily, is you also have fibromyalgia, which also puts you right into our widespread pain phenotype. So we have 5 core phenotypes. This is the system I use. It was proposed by the doctor who ran the IC research program at Stanford. Group 1, Hunner's lesions. Everybody agrees with that. Group 2, bladder wall driven. And in the bladder wall driven group, we're going to look for chemical injury, estrogen atrophy, or chronic infection. Group 3 is pelvic floor driven. These are patients with tight pelvic floor muscles. Group 4 is pudendal neuralgia. These are patients who have muscles that are entrapped by muscles. Group 5 is widespread pain. So these are the patients who have IC. Here, hold on. I got to turn on my heater. You guys tell me if you can hear that. It's getting cold here. A big storm's coming in again. So if you have IC, oh, it's not plugged in. Well, that sucks. No, it is plugged in. I'll have to figure that. I'll have to figure that out later. Let me go get a sweater real quick, guys, because the temperature just dropped. Hold on. Stretch. Stretch the legs. Stretch the legs. Okay. Okay. This is better. I'm older now. I like to be warm. I don't want to be cold. And you know what my PG&E bill was last month? $400. $400. That my thermostat is at 65 and it got to $400. That's how we're being screwed by our power companies right now. Okay. Okay, so widespread pain. Let's go back to widespread pain. So, if you have two or more of the related pain conditions, the IC, the IBS, the vulvodynia, TMJ, migraines, fibromyalgia, etc., you are in the widespread pain group. I'm in this group. So I had frequency urgency in 7th grade. I had severe vulvodynia in high school. Felt like I had a yeast infection all the time. Severe IBS in my 20s, early 20s. Then I had migraines for a bit. And then my bladder pain started when I was 32. Okay. When you're the patient, you want to know why. Why? Why was I condemned to live my life in pain while my friends were going out and getting married? I wanted to know why. God dang it. It still pisses me off because I did not get to have a normal young adulthood. I was laying in the fetal position in my bedroom or on my bathroom every day for years in my 20s. I had such bad IBS. Well, and that's all gone now. Just so you know, I am better now. And most patients are better now that we know the underlying cause. So, about 15 years ago, all the related pain groups got together, or most of them, and they created the Chronic Pain Research Alliance. And the Chronic Pain Research Alliance have been doing exceptional research. You can Google it, Chronic Pain Research Alliance. They have a fabulous website. Their research is just groundbreaking. So they're the ones who started looking at nerves. What's the connection between all these conditions? It's nerves. So they studied the nerves in the pelvis, and then they studied the nerves of the spinal cord, and then they studied the brain. Now, this is going to sound scary at first, but it isn't, and there's a very happy ending, okay? Just to let you know. This is what they found. Patients with widespread pain have a brain that is stuck in fight or flight. The 24 hours a day, 7 days a week, that brain thinks a threat is near. Normally, fight or flight is short term. Normally, if you were to open up your front door and see a saber-toothed tiger, of course you're going to go into fight or flight. But it's 2024. You're going to shut the door, call the authorities. They come out, they trank the tiger, they take it away. An hour later, the threat is gone. You've got a great story to share. But it's at that point the fight or flight is supposed to turn off. The sympathetic nervous system is supposed to turn itself off, and the parasympathetic nervous system takes control. The parasympathetic nervous system is the calm part of the brain. It lowers your heart rate, it lowers your blood pressure, it relaxes your muscles. So we're supposed to be relaxed. And really, fight or flight, it's only supposed to happen when a threat is sensed. But for patients with widespread pain, the brain believes 24 hours a day, your life is at stake. So your heart rate is up, your blood pressure is up, your muscles are tight, and boy, do you have anxiety. Boy, do we have anxiety. We are the no people. Hey, Jill, you want to go? No. You want to go to a movie? No. You want to go out to dinner? No, I'll have a flare. You want to? No. And I've asked a lot. I've done a lot of, I work with the top IC doctors, and I have for years. And I've asked them, why does my brain do that? Because I want to do all that. Why did my brain do that? And the answer is because your brain's in fight or flight and it's trying to keep you safe. It wants you to stay home because you're safe at home. So therapeutically now, we understand that patients with widespread pain basically have an injury. They have an injury to the central nervous system. And what the research shows is that for 80% of the children who develop widespread pain, that it's a physical injury where they were hit by a car, broke a leg, dropped as a baby, fell off their bike, fell on a balance beam, We know that 14 days will put the brain into a constant state, 14 days of pain will put the brain into a constant state of fight or flight. So it reminds me of a young woman that I was working with who I think was in her 30s. When she was a teenager, she broke her back, terrible back pain. Mother refused to take her to the doctor for 3 weeks, forced her to go to school. She had a severely broken back. When they finally found it, she was finally able to get treatment. And so she's now in this widespread pain group because that was an injury to her central nervous system. And for the other 20% of us, it's a history of bullying and abuse. And that was what happened to me. That in number one, redhead, seriously. Do y'all not understand how redheads get bullied in school? Well, in my case, I got bullied by a young man who was very mentally ill, who attacked me in 4th grade and raped and murdered my neighbor the year I went away to college. I did not leave my home without fear for a decade or longer. He hurt so many people. I have friends who will never set foot in my town again because they were so traumatized by this young man, severely mentally ill. We were not helped. So I was safe at home, but as soon as I woke up in the morning, fight or flight. Mom woke me up, Jill, got to get up, got to go to school. That's when fight or flight kicked in. And I walked to school back then, looking over my shoulder for him. And the closer I got to school, the more hypervigilant I became. And then when I was at school, we were all scared. There wasn't a kid in my class who wasn't scared. And then on the walk home, I ran home because that's when I was attacked, walking home. I was hurt physically. So think about what that did to my brain. 21 days of bullying or abuse at any age will put your brain in fight or flight. Honey, I was in fight or flight for 4th grade through high school. That's why I had an abnormal childhood and a young adulthood, because I was afraid. Another common theme we have in our office is growing up with a violent alcoholic parent. For those of you who had violence at home, school was your safe place. But I can remember I was working with one young woman who had a very violent father when he was drunk. And so, she'd come home from school, in her fight or flight. Dad came home, got worse. Dad started drinking, got worse. She'd hide herself and her siblings in the bathroom, lock the door. Dad would get so drunk, he'd break down the door and beat them. And she had all the pain conditions like I did. So if that happened to you, you are not alone. And none of this is your fault. You have done nothing wrong. No shame, no blame, not your fault. And it's not mental illness either. It's injury. It's actually a direct physical injury to the nerves. We call it a central nervous system maladaptation. So how do we fix it? It's actually fairly easy to fix with mind-body medicine that proves to your brain you're safe. If we give your brain good sensory information, safe sensory information, fight or flight turns off. We have a technique called I Spy. I do this with patients every day on the phone. You're always welcome to give me a phone call. I'd be happy to teach you all of these. No charge. Feel free to call. If you get me, great. If you don't, leave a message. I'll call you back when I can. Obviously, I get a lot of phone calls. But you're not alone if you have multiple pain conditions. You're not alone if you were abused as a kid. You're not alone if you were hurt as a kid. This is a big commonality for those of us with widespread pain. So if you do have widespread pain, we're going to add to your treatment protocol things that will calm your central nervous system down. And we got to work on the anxiety, because every time you have an anxious thought, you trigger fight or flight. So anybody wants to learn more about that, we can do that later. Sue said, why did they change packaging? I have no idea. Lizzie, Lizzie says, hold on. This is where I'm at. I think I have IC, of course. I was doing so well, slowly started back on coffee and another UTI. What am I doing wrong? Food, hormones, hygiene. I clean. I tried so hard not to eat sugar. It's so hard. I'm so sad. Lizzie. So again, you need to be phenotyped, hun. The real question is, why is my bladder vulnerable to food? It's either going to, and there's just very easy reasons why. Number one, it could be estrogen atrophy. If you're on birth control or you're a certain age, if you don't have the estrogen, your bladder can't produce the mucus, which protects your bladder wall. It could be very tight pelvic floor muscles. If your muscles are so tight, they're restricting blood flow to your bladder wall's not going to be healthy. We call that ischemia. And it could be a couple of other things too. So the fact that you started back on coffee and it triggered it tells me your bladder wall is not as healthy as it could be. What I don't know is how old you are. The fact that you got another UTI puts you in the recurring UTI group. The recurring UTI group is also because of estrogen atrophy. That's what the research shows. That 24 hours before the bacteria arrives in the bladder, it's usually in the uterus, or I'm sorry, usually in the vagina, not the uterus. It's usually in the vagina, living quite happily. And that then led the researchers to ask, what has happened to our vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer comes right back to estrogen atrophy. So if you want to, again, I'm happy to turn on Zoom and we can go into Zoom and we can try some phenotyping for people if y'all want to do that. If not, you're welcome to call or you can read about it on the IC Network website. But this is standard of care now. We have to figure out what group you're in before we talk about treatments because we don't want you to waste decades doing bladder treatments that have no shot of working. Mary says, if you continue to get Hunners after hydrodistension, I'm going for another to treat the Hunners. Is that ineffective care? No, I don't consider that ineffective care. That means you got damn difficult Hunner's ulcers or Hunner's lesions. And so we want to make sure, I mean, Mary, to me, I would want a viral. I would absolutely want a viral screen. I'm sorry. Whenever I wash my hair gets all weird, which is why I'm touching it all the time. It tickles me. It tickles my skin. I think it would be very, very important to have a viral screen to see if you have an active Epstein-Barr virus. Hi, Lalina. Debbie says, has anybody taken Umbrel? I haven't worked with anybody who has. Wendy says, can you get samples? I ended up getting some from my doctor, but ended up not using it. It caused retention. Jody says, Jill, where would mast cell histamine intolerance play in the 5 phenotypes? And bladder wall subtype number 2, bladder wall driven. Amy says, has anybody done InterStim? Amy, over on the IC Network website, we have a ginormous support forum where we have thousands of messages about InterStim from patients who have done them. InterStim, oh gosh, what do I want to say about InterStim? InterStim was developed in Northern California back in the 90s when I was a support group leader for Northern California. So I've been on top of InterStim for decades. The company doesn't like me very much because I have pushed and pushed and pushed because in the old days when they were doing InterStim at UC San Francisco, they didn't use anesthesia for the trials. And I had members of my support group screaming like a lunatic. And all you had to do is mention InterStim and patients started crying. It was just so incredibly awful back then. Thankfully the device has improved dramatically. And I was able to convince them to start doing anesthesia for those trial procedures. I was one of many, I'm sure. But fundamentally, Amy, InterStim has hundreds, if not thousands, of reported adverse events. And it's not it I have a big section on it on our website. There are two forms of neuromodulation. You can do the ankle stimulation, which we call post-tibial nerve stimulation. That's easy and affordable. They use an acupuncture needle as a vector to the nerve and attach a TENS unit to it, and there's no surgery. Yeah, I was a patient at UC San Francisco. Kaiser Permanente sent me to UC San Francisco after my diagnosis. Thank God I did not land in the InterStim group back then. I landed in the ankle stim group. The ankle stim group was created by Dr. Marshall Staller, who was so appalled by the trauma that InterStim patients were going through. He said, guys, you don't need to do surgery to access the damn nerve. You can access it down by the ankle at acupuncture 6, acupuncture 0.6, I think it was. And so to show an easier way of doing nerve stimulation, he developed a way of doing it at the ankle. And I did it. I did it like 12 times, and then they taught me how to do it at home. And it broke me out of a terrible flare, and I did not have to have surgery. And I still have my tattoos. I don't know if I can. Can you see there's a little tiny black dot right there? I move my finger. It's right there. And I have tattoos on both of my ankles. This one might be easier to see. See that little black dot right there? So basically, they put a acupuncture needle in here, but you have to finesse it. And then they attach a TENS unit to it. 20 minutes once a week for 10 weeks. It's a protocol. By week 3, I had my first 2 hours without pain. By week 7, I had my first day without pain. I truly believe that the ankle stimulation broke me out of a year-long flare. So getting back to the InterStim, InterStim was bought by Medtronic. The doctor who invented it transferred to the University of Colorado. He got fired. And it was just a whole drama, lawsuit drama, all sorts of stuff like that. There are a couple of things you need to ask about InterStim. So there is a place for InterStim. InterStim is not approved for IC. InterStim is approved for incontinence and frequency urgency. InterStim requires at least one surgery. They're going to do a surgery to implant an electrode. They'll do a 2-week trial, and they will collect that electrode to a TENS unit that you might wear, like on a belt or in a pocket. If it seems to work, then 2 weeks later, they will ask to implant that box, the generator box, somewhere in your butt cheek, in your upper butt cheek. InterStim has been plagued with side effects. And if you go to, and let's just do this right now, because I think this is really important for people to see. So I am right now, you guys remember the old TV show Maude, Maude? You can open Google and search for the Maude FDA database. That is the manufacturer and user facility device experience. This is where companies are required to report adverse events with medical devices like InterStim. So I've just opened that up. Now what I'm going to do is under brand name, I'm going to put InterStim. And I'm going to adjust the date, and I'm just going to do from January 1st, 24 to February 20. I don't know why it defaulted to February 29th. Well, let's do that. You can go back years. There are hundreds and hundreds of reports. So anyway, let's go ahead and do that. So I'm doing that right now. Okay. So I've got on the first page alone, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 reports filed on February 28th for problems with InterStim. So let's look at it. Let's see what we got. Okay, very first one, migration or expulsion of device, insufficient information. Medtronic is submitting this report to comply with FDA reporting regulations. This report is based upon information obtained by Medtronic, which the company may not have been able to fully investigate or verify prior to the report, yada, yada. Okay, so here's the event. Information was received from a patient who was implanted with the implantable neurostimulator for urinary bowel dysfunction and urgent incontinence. It was reported that nothing is working, nothing is helping since the implant. Patients met with a PA, but the PA refers the patient to Medtronic. Patient said after the implant, they used program 1, and it increased, then went to program 2, and increased over time, but they're still leaking. Patient requested program information and assistance. During the call, patient was successful in changing the program. Patient, yada, yada. Okay. So this was a patient who was having trouble finding the right setting. One of the more common adverse events are deep tissue MRSA infections. Here we go. Here's somebody, patient who was implanted for urinary dysfunction. It was reported that the patient received their new programmer. When they tried to connect it to their implant, they saw a message, low battery, contact your clinician. Patient said they have not felt stimulation for over 2 months and are still wearing diapers. The patient was redirected to their healthcare practitioner. They reported the patient called in stating they needed the device replaced, but the healthcare practitioner said they are waiting on the device from the manufacturer and won't schedule the replacement until they receive the device. Okay, that makes sense. All right, let's look at another one. Here's one patient. It was reported that the patient states that their device has never worked. The patient was provided contact information for a provider when attempting to connect. The provider's office did not answer. Patient was also provided with the number for patient support representative. She's been unable to connect with anybody. The cause of the device not working was undetermined. They never checked the device. The patient is getting a new device on February 15th. The issue was not resolved. Okay. So there's 10 filed on February 28th. Oh, so there are 500 adverse event reports filed in 2 months. Okay. And if you do a deep dive into them, as I have done, there are fatalities. The last time I counted up, there were almost 20 fatalities that had been reported to the FDA as being associated in some way with the device. And the problem with the MOD database is you get no follow-up. You have no idea. Nothing is clarified. It's just a doctor saying, hey, a patient died. That might have been from the device. I have talked with some of the top InterStim people who have the best records doing InterStim, and I actually challenged one at a conference and said, "What do you think about the fatalities?" They go, "Oh, people die." I'm not happy with that. So over on the IC Network website, I have a lot of questions for you to ask your doctor about InterStim. Especially things like, how many have you done? What adverse events have you seen? How have you resolved these adverse events? And if you have a doctor who says there are no adverse events, they are gaslighting you. Because I just found 500 in less than 30 seconds filed with the FDA about this device. Now, there is a place for InterStim. If we have a patient who's completely incontinent and they've tried everything and they have stool incontinence and they've got urine incontinence, InterStim can absolutely be life-changing, no doubt about that. If it can turn off their incontinence, that would be amazing. I'm not against InterStim. I think InterStim has a place, but you need full and complete information first. And then the last thing I'll mention about InterStim is if you have a doctor who wants to do it, you need to get in writing from your insurance company that it is covered by your health insurance. So we had a nurse who she lived in a small town. There were only like a handful of urologists in the area. They all told her she needed InterStim. She was a nurse at the local hospital. So she did her due diligence. She went to the urologist billing office and said, "Is this covered by my insurance?" They said, "Yes, no written pre-authorization is required." She then went to the hospital billing office and said, "Is this covered by my health insurance?" They told her, "Yes, it is covered. No written pre-authorization is required." She called the insurance company, said, "Is this covered?" They went, "Yes, no written pre-authorization it was required." The mistake that she made is that she didn't get it in writing. And a week after she had the surgery, they threatened to garnish her wages for $80,000, somewhere in there. Because guess what? It wasn't effing covered by insurance. So always get in writing from your insurance company that it is covered. And understand with InterStim, it's at least 3 surgeries if you go all the way through. It's a trial, it's the implant, and then it's the removal. And if it doesn't work, get it out, because the longer it's in there, the harder it is to remove. It's not normal to have metal in your body. So, and obviously they have improved the technology, but with all due respect, with all the improvements, why are there still so many adverse events filed with the FDA? That's what I would like to know. Now, I have not gone through, the last time I went through a couple hundred adverse events was maybe 5, 6 years ago. And that's when I found the fatalities. There was one report of a woman whose heart started beating in time with the stimulator. That was crazy. But I haven't seen trends, the recent trends. If I had a grad student working with me, that'd be something that I would pay them to do, is to go through all that stuff. Jody says, "Redhead here, I get it." Oh my words, Jill. Sue said, "I've done InterStim for 20 years ago and again 3 years ago. If you want, I'll talk to you about my experience." Yeah, Sue would be a good reference. Okay, you guys just know, again, Facebook is just like all over the place here for me right now. It's constantly going up and down in the messages. Heather says, "Does your friend still have frequency urgency following nerve treatment?" Okay. Thank you, Anne. Okay, you guys are talking to each other, so I'm not going to answer those. Heather says, "I'd like to hear her answer regarding the mast cell." If I answered it, great. If I didn't, ask it again. God, you guys are doing so good talking to each other. Jody says, "I worked with Urogyne and InterStim was a huge failure for almost every patient." Yeah. Really, the patients are going to be the most successful with InterStim are going to be the patients who are working with the best surgeons, like Dr. Ken Peters or Robert Evans. Wendy said she did the trial and it made me worse. My nerves went crazy. Yeah. Sue said, "I had InterStim removed this year after I had a couple of falls where the lead went in. Um, if I sat on your sit bone too long, it would cause nerve pain in my leg to shake. I didn't feel what I was getting was worth it." Yeah. Diane said, hold on. "Does anybody have trouble with hemorrhoids in addition to IT?" Girl, I believe mine is due to problems with the pelvic floor. Hemorrhoids happen when you're straining. If you're straining to have bowel movements, if you're straining to release urine, that's when hemorrhoids happen. So yeah, there's a definite correlation between hemorrhoids and a tight pelvic floor. Jody said, "Can you help me understand why I'm in remission 99% of the time? Do I have IC or perhaps just mast cell histamine intolerance?" Well, Jody, what that means is that you're an injury patient and your injuries heal, but then you hurt them again. I would bet you money that you're a neuromuscular patient as compared to a bladder wall patient. And the mast cells might not be playing as big a role as you think they are. Again, we would want to try to subtype you or phenotype you. Diane says, "Where do you find a doctor who does the ankle stimulation?" It's called Urgent PC. Just Google Urgent PC. In fact, let me do that. And you guys on YouTube, you're being very quiet, and I'm sorry if I'm missing your questions. Okay, here, hold on a sec. Let me see if I can find that for you. Urgent PC. So the name of the company is Labori, Laborie. It's changed hands a couple of times, or the company's been sold a couple of times. So Laborie, Labori for overactive bladder. And they have a doctor finder on their website. Or Heather says, "I believe they get kickbacks for how many people they refer, not suggesting that that is, but it always could be." Well, there was Medtronic has several years ago paid the largest fine in US history for paying kickbacks to doctors for doing another medical device. I don't remember the details of that, but we wrote about that extensively. It wasn't InterStim though. I think if I remember correctly, it was an employee who turned them in. This was probably 15 years ago. Oh, here it is. To help Medtronic gain market share, its sales reps provided kickbacks to hospitals and gave away expensive medical equipment with the fraudulent name of samples, loaners, or demo units. And this was oh, wait, what? Wait, what? Is this new? Hol Let me just read this. Holy shit. Excuse me for swearing. This is from the website icij.org. icij.org. This is newer. Holy moly. This was written January 31st, 2024. Whistleblower accuses medical tech giant Medtronic of putting profit before patient. ICIJ's implant files uncovered controversial deals between Medtronic and hospitals around the world. Now, a former U.S. sales representative alleges the company used kickbacks and pressure tactics to make sales despite patient injuries. Late in the summer of 2018, several surgeons at the McLeod Regional Medical Center in Florence, South Carolina, grew increasingly concerned about the quality of a vital surgical tool they relied on in their operating rooms. The GI-80 surgical skin stapler produced by Covidien, a subsidiary of Medtronic, did not properly hold incision edges together, or the internal knife malfunctioned during appendectomies and other critical surgeries. This led to unnecessary and sometimes dangerous bleeding in patients. In September 2018, a McLeod general surgeon wrote on a product complaint form that, quote, as a stapler approximated, it tore the small bowel 3 times. Each time, Bruton had to cut out more of the bowel to repair the tears. He wrote unacceptable in capital letters on the complaint form. He suggested that the medical center return to a type of stapler they had used previously, one produced by a Medtronic competitor that hadn't caused such problems. On the same day, another surgeon, Keith Player, requested procurement managers return to staplers produced by the same Medtronic competitor. Wow. Wow. I am not going to read the whole thing here. Let me go down here though. The product complaint forms detailing the incidences at McLeod, as well as Medtronic's response to the physicians, are part of a recently unsealed court case against a medical equipment giant brought by former Medtronic sales rep Leanne Houston. Between 2016 and 18, Houston says she was privy to Medtronic engaging in, quote, unlawful conduct, as she characterized it in the complaint. Among other things, she says the company covered up problems with certain models of surgical staplers and illegally paid physicians in 6 hospitals in the McLeod Health Network and at other hospitals in the form of millions of dollars of free medical equipment so that they would, quote, commit to only using Medtronic surgical products and ending relationships with other suppliers. Quote, Medtronic put profit before patients, end quote, Houston alleges in her complaint. Quote, the entire business model for Medtronic revolved around giving kickbacks to induce a hospital or surgeon to purchase its devices, even if they were more expensive or medically unnecessary or even harmful to the patient. She filed a lawsuit under seal in 2020 after she was fired for speaking out regarding fraud and device concerns. The case became public in late 2023 when the Department of Justice announced its decision not to intervene without providing a specific reason. In 2018, this investigation found that governments on 4 continents had accused Medtronic of promoting unauthorized use of products between 2011 and 2020. Medtronic and its subsidiaries paid more than $60 million to settle fraud or kickback allegations. Holy crap. Here, I'm going to give you guys here on Facebook the link to that article. Holy moly. Oh, that shocked the heck out of me. And for you guys on YouTube, just Google Medtronic whistleblower accuses kickback, something like that, and you'll find it. Okay, well, oh, sorry, I took a turn there. I'm stunned because like 10 years ago, 15 years ago, we went all through this. Wow. Again, not to be political, but big pharma and these companies have too much power. They're setting prices, and we truly need much more oversight. And if you want oversight, you got to vote blue, my friends. I'm sorry, it is what it is. If you want cheaper prices, you got to do it. All right, let me go back to your question. Sorry. Amy says, I really appreciate all that info on InterStem. I wonder why my urologist is so adamant on doing it. I'll ask him more questions. Well, I think you might have just gotten a little idea. Maureen said, I had mine replaced twice. I feel it gives me great lower back pain. I told my urologist it's causing too much pain. She refused to believe me. So you're looking to have it removed. Yeah, I mean, that's like the other thing. That's the other big challenge that we've had is getting them to listen to patients. I mean, there was one patient that I was working with who she had it implanted, and I mean, her trial was successful. She agreed to the implant. She knew as soon as she woke up, there was a problem with it. And the doctors wouldn't listen to her. And they kept reprogramming it. And they kept saying, well, this is normal post-op recovery. You had surgery. Of course, you're going to have more pain down there. Well, 4 or 5 months later, when she ended up in the hospital, she had gangrene and nerve damage because there was an infection that the doctor just didn't take the time to look at. And this is, again, if you look at the information that I have on InterStem on the IC Network website, one of the questions is assessing the experience of the doctor who's proposing to do it. You don't want a young gun doing this. And even our AUA guidelines now say for any time you're looking at bladder surgery, for God's sake, you need the cream of the crop. You need the most experienced urologist doing surgeries like this. And so it is a challenge. Diane said, can I learn to use a pelvic wand to help my tight pelvic floor muscle by myself from watching YouTube videos? No. The physical therapist I saw told me I could, and I bought the wand, but no longer see the physical therapist, so you're going to try it out on your own. Okay. So, Diane, the only way you're going to learn is doing it. You have to learn what healthy muscle feels like. So when I do my muscle work, I lay on my bed, I put my feet up on the wall, and here, let me get a wand. That's empty. Okay. So this is the wand that I personally use. We sold this for many years on the IC Network website, but it changed hand. The company was sold to another company. So now, if you want to buy the last wand, you have to get it from Desert Harvest. We don't sell it anymore. Okay. So anyway, so when I do my wand work, and really, all it takes is 5 minutes. As soon as I feel a muscle getting tight, I can get in and massage it. It will drop down, relax, and I'm good. Okay. So I lay on my back, on my bed with my feet up on the wall. So essentially, I'm in this position. Okay. Or no, I'm in this position like this. Okay. Now, let's look at the back here for a moment. Your tailbone is the center of your pelvis. It's the center. And you've got muscles that go from the left and muscles that go to the right. Healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like beef jerky, and it's tender to touch. So when you are doing your insertion, obviously this is wash, use a little bit of KY, and you're going to insert the wand into your vagina, and you're only going to do one side, and you just kind of gently touch muscle to try to figure out if it's tender or tight. You'll do one side, and then you'll do the other side. And that's the part that's that's the learning curve, is you learning your body to feel what's normal and what's abnormal. I didn't know how to do it at first at all. I mean, I bought the wand, I had the physical therapist. She kept saying it's a J shape. move your wand in a J shape. And I'm like, okay, I know what a J is. It's like that. So I go home and I'm like, okay, how do I move it in a J shape? I have no freaking clue. Well, I now know the J shape. This is the J shape. So if this is your center, imagine two capital J's touching each other. You've got a J that goes up this way and a J that goes up this way. So generally, when you're doing your internal work, you're going up like this. You actually are doing kind of a J that kind of starts by your tailbone and goes up along the length of the muscle, one side and then the other. Sometimes they will have you do a strumming where instead of following the muscle, you go across the muscle. And that's just kind of a nice way to get that muscle's attention to get it to relax and release. And sometimes, if you find a trigger point, which is a knot, you just put pressure on that knot with your wand. But always, normally, it's the physical therapist. And I always tell patients, I think you need to have a physical therapist guide you in how to do this because number one, you don't know which muscle is the problem, and it's important for them to tell you where you should be working. And then they can give you guidance on how to move it because I don't know what muscle I can't demonstrate for you what you should do because I don't know which muscle is the issue and I'm not a physical therapist. I can only tell you what they told me. I will also say that I'm very gentle with my wand. There have been moments when I pushed harder and I could tell that I was pushing on a nerve and I immediately backed off. So I do think having that physical therapist's guidance is really, really your first priority. So, so if you go to pelvicrehab.com, you can find other physical therapists that are working with the pelvic floor, and maybe you can find another one who will give you some tips on how to do it. All right, so we have our first person who left because I said vote blue. Guys, all I'm saying is if you want reduced drug costs, if you want more accountability, yeah, we have lower insulin prices right now because of the blue side, and the red side voted against it. It's that easy. See ya, Patricia. No offense. Sue says, my interest went in and came out without or without any complications, but I did see a very good doctor. It's my choice to do the interstim. I do believe the trial is hard to know if it's helping you or not because so many of us are fluctuating. Heather says, what do you think of the non-estrogen inserts for moisture for dry skin internally? I'm only familiar with one or two, and they're not going to be as effective as an estrogen product. If you can't use estrogen for one reason or another, then you're going to have to do something that will give you a little bit of moisture. Otherwise, you're just going to get really, really dry. I really like a vulva balm V Magic to use externally, but not internally. The internal vaginal lubricants, I'm not as familiar with. Sue said, I have very little pain when having interstim put in or taken out, except for some itching when healing. I would not think pain would be normal. Okay. Jody says, I have to go. See you later, Jody. Nice to meet you, hon. And congratulations again. Sue says, I see a couple of really good recommended physical therapists over the years. They also don't seem to like the wand. I don't know why they do internal, and I've asked them both if I should use it at home, and they did not recommend it. But I still use mine at home, and my doctor told me it was okay to use it, and I do, just like what Jill says. And I also have a book that talks about it. Okay. Hey, John, nice to see you. I really struggle with internal work, and haven't found any way to make it easier. Yeah, John, sorry, but sometimes you're tight because of biomechanics, like having one leg longer than the other or having a hip that's rotated. And then it gets really tricky. It gets hard to deal with that, but you got to keep trying. Anyway, I never want to be political. But at the same time, you know, we have to think about how can we get better healthcare. And so I try not to talk about it very much, but I did bring it up twice and we did lose somebody and I'm sorry for that. But it's what it is. Would anybody like to go into Zoom? It's 3:30. I've been talking pretty good on my throat for 2.5 hours, but my throat is getting close to the end here. So would anybody like to go into Zoom to talk to me personally or to be phenotyped? If you would, let me know and I'll start up Zoom. If not, that's fine, and we'll go watch the Academy Award. What would you like to do? You tell me, my friends, what would you like to do? Oh, Angel would like to do Zoom? Okay. Oh, hey, listen, one last thing. This was very interesting. We have our first study in which they have found a correlation between pelvic pain and hypertension, high blood pressure. And I emailed the researcher. This was done in the United States. And here's what they found. So they were studying patients with IC and chronic prostatitis. They were talking about some very specific mechanisms, which are too scientific for us to talk about right now. They aim to test the hypothesis that urologic chronic pelvic pain patients have dysregulated angiotensin signaling, resulting in increased hypertension compared to controls. Secondly, we evaluated symptom severity in patients with or without hypertension. The results. So they studied 424 patients, 200 controls, and 415 healthy controls from the National Institutes of Health. So this was, you know, our big IC research team at NIH. They found that the combination of the diagnosis and antihypertensive medications used was highest in the pelvic pain group, followed by healthy controls. 18% in the pelvic pain group, 12% in the controls. There's no difference in symptom severity. So they said this pattern of findings suggests that there may be a relationship between hypertension and pelvic pain. So now this made total sense to me. John, you can find it on the National Library of Medicine. Just hypertension and urologic chronic pelvic pain. I don't have the link for it. Anyway, okay, so this came as no surprise to me. So I emailed the lead researcher and I went, okay, I'm not surprised by this. Did you apply phenotypes to it? Because for the patients with widespread pain who are in constant fight or flight, of course they're going to have higher blood pressure. And so my response back to them was, this comes as no surprise. When you phenotype them, I bet the patients with high blood pressure are going to be the widespread pain patients. And he's like, yeah, you're probably right. They just hadn't thought of doing that. So I thought that was an interesting study. If you're looking for a physical therapist, you go to pelvicrehab.com. Pelvic Rehab, short for rehabilitation.com. Okay, I'm going to go ahead and start Zoom, and we'll see if anybody wants to come in. If not, we will be done, but that's okay. I'm here. Let me start it up. Okie dokie artichoke. Let me do that. Let me start my video. My video is started. Now let me get my invite. Okay, so for those of you on Facebook, here is your invite link to on Zoom. Sarah says, "Have I heard of a hydrodissection only for Hunner's lesions, hon? Only for Hunner's lesions. I don't know what else they would be trying to do, if that is what I think it is. That's not a word people use very often." All right, YouTube, hold on one sec real quick. I actually have to send an email to my other computer with the link. So give me one sec. Let me just send myself that link. All right, done. All right, here's the link. Let me copy that. And let's go ahead and put that into your chat. All righty. Okay, so you have the Zoom link. If anybody wants to come into Zoom, they want to be phenotyped, or they just want to ask questions directly, come on in right now. Otherwise, we are at the end of our Facebook and our YouTube meetings. I hope to see you. Okay, John's here. John's entering the room. I fully intend to be here next Sunday, but I will tell you we are having a baby shower next Sunday. So I might do a short meeting so that I can drive up to Healdsburg and go to my nephew's baby shower. All right. So, but I am hoping, God willing, that I will be here to do a support group meeting next Sunday. All righty. So if anybody has any other questions, feel free to come on into Zoom. Angels come in too. Otherwise, we're going to say goodbye. Have a fantastic week. Sleep well. If you want to learn more about IC, come to the IC Network. If you find these meetings helpful, please think about becoming a member. All right? Okay, guys, I'm going to say goodbye to Facebook and YouTube. I'll see you later. Bye, YouTube.